Hello.
Hi, Megan. Nice to see you.
Nice to see you. Thank you so much for joining. I see we've already got some people that have popped in. So, this was the fastest anybody has ever joined a live. That was very, very exciting. um, yeah, so in the interest of time, I will make sure we go ahead and get started so that we can ask all the questions. So hi everybody that is with us. My name is Megan Hansen. If you haven't followed us for a while, you don't know anything about who I am or who we are. I am the president and co-founder of Recurrent Pregnancy Loss Association, RPLA. We are a nonprofit organization for the families of people that have lost multiple pregnancies. And our goal really is to try to advance our understanding of why this happens and hopefully eventually prevent it. So we do a lot of these types of educational events. We do a lot of community support. We have a support group that's free for anybody to join. And then we're also trying to raise money so that incredibly smart doctors like Dr. Lathi and Dr. Tise can do more research and help us stop RPL. So when I'm really excited about this conversation today because when I was first getting started and just talking to people about what I wanted to do and who I should be learning from or asking questions about, everybody pretty much that I talked to in the space said, oh, you've got to talk to Dr. Lathi. She is, I think, hands down, like one of the national experts on recurrent pregnancy loss. And so it's really a treat that we're going to get to hear about her work today and hear from her about how she is managing the patients that she sees in her practice. So I will go ahead and introduce both of these incredible women, and then we can get started. So as I said, so Dr. Lathi, she is a professor of obstetrics and gynecology and the director of the Recurrent Pregnancy Loss Program at Stanford University. She has a special interest in RPL, as well as the role of pre-implantation genetic diagnosis in the treatment of reproductive disorders, the prognostic value and utility of genetic testing of miscarriage tissue, which we have another Instagram live about if you want to go back and watch that one where we talk specifically about testing miscarriage tissue, as well as she's interested in the long-term outcomes of fertility treatment. Right now, she is currently the principal investigator for a multi-site NIH-funded study, which is trying to investigate genetic, environmental, and systemic causes of loss. And she and her team really are searching for what are those causes of unexplained pregnancy loss, as well as recurrent pregnancy loss. Dr. Tise is part of that research team for that NIH study and is a physician scientist and assistant professor in the Division of Medical Genetics at Stanford. And she has a subspecialty training in clinical biochemical genetics, which is way over my head even saying it. Dr. Tise's clinical area of expertise is in the diagnosis and management of individuals with genetic conditions and prenatal and reproductive genetics. And so her research is focused on the genetic etiologies of recurrent pregnancy loss. So really the kind of causes of this, the impact of inherited metabolic conditions on human reproduction generally, and the clinical utility of technologies and new technologies for diagnosis and treatment of these conditions. Ladies, thank you so much for joining. I want to start, those are obviously incredible and very sciencey bios. So I want to start with maybe just a broad question of, for each of you, why are, first of all, thank you, but why and how did you get interested in recurrent pregnancy loss? And yeah, what brought you to this space and what keeps you interested in it?
Okay, well, I'll go first. Thank you so much for organizing this event for us, Megan, and for all you do for the community in recurrent pregnancy loss. We know how important it is to have that community and to work together and really just stick together for this really challenging disorder. So when you ask what brought me to recurrent pregnancy loss, really even before the science, it's the patients. There's a lot of misinformation out there that really just kind of got me excited about looking into this. Are these things true? What are the real causes of pregnancy loss? And all the myths that are out there about If you've had, you know, 2 miscarriages or 3, you'll never have a child. And we just know that's not true. There's a lot of hope. A lot of women who have been through multiple pregnancy losses do succeed with good care and with, you know, what the evidence and what we know right now. We can help a lot of women, and it's really gratifying to be in a field where we're actually able to help women and families get through a really challenging time to achieve their goals of having a baby. So really it was that got me initially interested in this field. And, you know, what's kept me involved is just how much we're learning every day, and the science, and really just the inspirational stories from our patients.
Thank you. I love that.
Yeah, and you know, for me, Megan, and again, thanks for putting this together. I think, you know, like Dr. Lathi, I want to help women, want to help children from a physician standpoint, but from a research standpoint and genetics, you know, our understanding of genetics is really at the tip of the iceberg at the moment, but very quickly learning so much more in a really short amount of time. And when you think about human disease and genetic conditions, there's probably, given the number of genes that we have, so many that are important in fetal development, that maybe are so important in fetal development that when they're not present or they're altered in some way, results in things that we never see actually in the living population, and so results in recurrent pregnancy loss. And if we're able to identify these things, not only can we understand a bit more about human human pathology and biology, but we can also help families with recurrence risk and planning.
Oh, thank you so much. So, which I guess, you know, you kind of teed that up really nicely, Dr. Tise, because when we say genetics of pregnancy loss, like, what does that even mean? So when you know that you both are studying the genetics of pregnancy loss, or how genetics relates to pregnancy loss, it's broad, and there's multiple ways. So can you say, like, what does that actually, what does it mean?
Well, there's really 2 main categories of genetic conditions that cause pregnancy loss. One are whole chromosome abnormalities that are random or sporadic in nature. So these are, you know, defects that are, or abnormalities that occur in fetuses and embryos that are not specifically inherited from mom or dad. So when an egg or a sperm is formed, they get an extra or a missing chromosome, and that embryo doesn't have a whole bunch of genes that it needs. So that's the whole chromosome, or what we call aneuploidy abnormalities that we see in a lot of our miscarriages. But there are other types of genetic abnormalities that we're still learning more about, and I'll have Dr. Tise, that's her expertise.
Yeah, and so, you know, there's what, you know, Dr. Lathi mentioned with the larger chromosomes, but there's a lot that we have yet to discover. I think, you know, like what we can see, the things that are bigger have been better appreciated over time, things that we were able to see with things like karyotype and microarray. But we're realizing, as we know more and more about the human genome, that, you know, there's things just at the single nucleotide level, or at the, you know, single letter, you know, in a book level, that have to do with human development that are critical, that we didn't really recognize before. And to be honest, we did have some realization of this. We just didn't have the technologies to identify them previously. Mm-hmm. So when we're talking about the genetics of pregnancy loss, I think it's encompassing of all of those things. And I think you bring up a really great point that, you know, I think by nature, the word genetics, I think people think means inherited or passed on, but there's a lot of genetic conditions that aren't inherited, but they're still genetic in nature. And we're realizing in time, more and more things are what we call de novo and new. And so, you know, even figuring that out for families, if they're new versus inherited, is quite important.
No, I think that's a really important distinction. You know, one of the things, and I actually think one of the frustrations that I hear from a lot of families that have experienced multiple losses is this kind of comment. And it's nice because it's like, we know that these losses are never the couple's fault. But one of the things that's said really frequently is, oh, well, you know, most losses are a result of like a chromosomal abnormality, or most losses are because there was, you know, because of that. So that can be frustrating, particularly when products of conception haven't been tested. And it feels a little bit like, oh, has my lot, like, is the cause for this being dismissed? But from your perspective, how is that statement, like, most of these pregnancy losses are a result of something chromosomal? Is that an accurate statement for the recurrent pregnancy loss population, even if they haven't had the miscarriage tissue tested previously?
Yeah, I think, you touched on a lot of really important parts of caring for women going through miscarriage. That from a explanation perspective, I think getting the chromosomes is very, very important. We know that even in the setting of recurrent pregnancy loss, for most studies will say that about half, if not more, pregnancy losses, even in the setting of recurrent pregnancy loss, will be chromosomally abnormal. It is very, I've heard this from many of my patients, and as you started to articulate, is, that they may have not had the opportunity to test their pregnancy loss, and without a concrete explanation, our brains just have these questions. And I found it to be very therapeutic to give an explanation to my patients whenever possible. So as a general rule, whenever possible, I am recommending that we get the chromosome testing. There's this sort of myth or thought that, oh, there's nothing I can do about it, so why test? But I think that what I hear from my patients all the time, and I'm sure, many people listening to this, the number one question that I hear is, why is this happening? Or what was the cause of my miscarriage? I can read a textbook too, and I know that statistic that most are chromosomally abnormal, but it's helpful to me as a patient, as a person going through this, to know, is that me? And so when we're talking about taking care of individuals and giving as many answers as possible, it's we can't always give patients an answer, but whenever we can, it is therapeutic and it's helpful. So I do find that it's very helpful. On the other hand, it isn't routinely done, and there's a lot of reasons for that. I think that number one, a lot of miscarriages happen at home or in an emergency room, or an environment where they're not seeing a miscarriage expert at the time of their miscarriage. I see most of my patients after their miscarriages, and so it's just not commonly offered in emergency rooms and for patients who are undergoing miscarriages at home. And then even when patients are having procedures for their miscarriages, there are other variances in practice where there may be concerns about costs or insurance coverage or other things like that, which may be getting in the way as well. But from a medical and an emotional perspective, we really have shown that the majority of patients, whether their chromosome test comes back normal or abnormal, are grateful that they had the testing done. And it is helpful in moving forward. Once we have that information, we can make some decisions about what additional tests could be done. Do you need any more testing? If we have an explanation for your pregnancy loss, then we're done. We don't have to look for other causes. However, if we're seeing chromosomally normal losses, these are the patients that don't have explanations. That's what keeps Dr. Tise and I up at night, and why the NIH has given us money to do this research, to really try to understand what percentage of those miscarriages are actually due to genetic problems that are not detected by standard testing. Right. And then also, our next aim would be, once we've ruled out genetic causes, what are the other systemic or environmental or immune causes that are seen in these really, truly unexplained pregnancy losses?
Yeah. No, that's thank you for that. I think that's really helpful. So it sounds like, yes, we do know that the majority of these losses are happening for that reason, but that doesn't mean that we shouldn't kind of take that if it's available and if patients are kind of comfortable with it, that having that information can be helpful both from a diagnostic perspective and sort of from a closure and like psychological perspective.
Absolutely, Megan. And I'll just add to that, if you do a test 1 in 100 times, but you give the answer for one family, and only one family, I think it's still worth everything to that family. And that's been our experience with genetics for many decades. It's just in the recent decades, the availability and access to genetic testing has exploded, which is wonderful. In fact, it's actually, moving a little bit faster than the clinical field can keep up with, because the research is happening so quickly. But with this, and we're seeing this in the pediatric population, in children who, have a diagnosis for something I think 20 years ago we would have said is absolutely not genetic in etiology. Now that we have the test and we can, test these individuals, we're finding that way more of the population has an underlying genetic etiology than we previously ever thought or imagined. And so we won't really have a really good idea of how much of recurrent pregnancy loss is genetic in etiology until we have a better understanding of human genetics and we're doing more testing at the same time.
And I want to make sure that we kind of talk about the research that you're doing about the testing and kind of what you're looking at. But maybe before that, I want to just back up, as we start to talk about genetic testing, Dr. Lathi, you said that that there's a lot of other things that you're looking at, particularly for those couples that it's something that's unexplained. So from your experience, and I know kind of each couple is different, but as a general rule of thumb, can you share what is the typical workup that you're doing for the couples that are coming to see you? What would you kind of recommend to anybody listening that, or to their doctors? Like, what do you recommend are those things that are looked at? Do you typically do things that are beyond the ASRM recommendations? What additional do you do routinely in terms of testing? I think it would be helpful for everybody to hear that.
Yeah, I think that it's important to just know, and I'm sure you can echo this, that every couple is different. We do believe that, and we have good evidence that most miscarriages are due to a problem with the embryo. And an embryo is made of eggs and sperm. And what determines the health of those eggs and sperm? The health of the mom and dad. So for every single patient, regardless of the history, we really want to focus on physical and emotional health of mom and dad, or egg and sperm source, whichever, however we're conceiving at this point. And so that is number one for all patients going through this, regardless of their number of losses, the gestational age of the loss, early or late, whether there were obvious complications in the pregnancy or not. So I really do want to get a detailed history from both parents, as well as the timing of the loss, what were the prior treatments, and what, if any, genetics do we know about these losses. But as a general rule, as I mentioned, most patients come to me without having had any prior genetics on their pregnancy losses. So we're kind of stuck without answers. And we definitely do start with the ASRM guidelines. And ASRM is our sort of national fertility society. It's the American Society for Reproductive Medicine. And it's, thousands of reproductive medicine experts who have contributed to these guidelines, looking really at not just what tests are available, but what tests have been proven to be effective in guiding treatment and predicting the chance of another pregnancy loss, or even predicting response to therapies. So other than genetics, and my first choice is always to check the genetics of the miscarriage whenever possible. But if I don't have that, we can check the genetics of the parents through a chromosome test. Although it's extremely rare, there are conditions where egg and sperm sources may have chromosome rearrangements themselves. That puts them at a higher risk of having an abnormal egg or sperm produced as the eggs and sperm are developing in the body. So we check, if we don't have genetics on the miscarriage, the next best thing we can do is check genetics on mom and dad. The other known causes really are to look at uterus anomalies to make sure that there's a healthy looking and shaped uterus, no obvious congenital, that the uterus developed normally when the gestating parent was a baby themselves, or acquired problems such as fibroids or infection or scarring or polyps that could develop over time. So we do actually look at the uterus pretty closely. As I always tell my patients, we spend a third of our time talking about how do we get healthy eggs, a third of our time talking about how do we get a healthy uterus, and a third of our time talking about how do we get healthy sperm, because all those three are critical to the growing pregnancy.
Yeah.
And then lastly, there's a rare condition called phospholipid syndrome. It's a clotting disorder that's immune mediated, where women can develop abnormal blood clots. Their blood gets too thick when they're pregnant, and that can cause pregnancy complications and pregnancy loss. So those are the main things that we really focus on. And then we take clues from the history, what other medications they're on, what other health conditions do they have, to try to optimize the health of both parents before the next pregnancy.
Yes. No, thank you for that. Actually, I like that. A third on the kind of the egg, a third on the uterus, a third on the sperm. That's the first time I've heard that, and that makes a lot of sense. Thank you. And I will say, obviously we could have whole hour-long conversations on each one of those. So I'm not going to do that right now. And for those watching, we do have some videos posted around specifically male factor related to recurrent pregnancy loss. Katie Lee Hornberger, a genetic counselor, did an entire session with us talking specifically about some of the tests that Dr. Lathi just referenced. So you can go back and watch those. I apologize that we're not going to have time to dive into all of that right now. But I wanted to ask then, as it relates to genetics and our conversation about, sometimes not having tested prior pregnancies and not really knowing if that's the cause. One thing that more frequently, I would say, I think people are being recommended is, oh, well, if we think that this was maybe caused by some genetic issue, we'll do IVF, we'll test the embryos before we implant them, and that sort of minimizes the risk of this being a problem. Can you comment on when that is appropriate, why it might be appropriate, and when it may not be appropriate for couples that are experiencing recurrent pregnancy loss?
Yeah, that's a really hot topic right now. It is, so you're talking about IVF, which is creating embryos outside the body and testing for a known genetic problem. And in cases where the parents have a known genetic problem, like a translocation, we know that puts this couple at a higher risk for another genetic miscarriage. That I think that when we look at a couple that doesn't have a known genetic cause, it becomes a little more murky. We know that anytime we're looking at a technology, a treatment, we always want to look at pros and cons and costs, and what are the success rates with treatment versus the success rate without treatment. Because as I mentioned really much earlier in this conversation, a lot of our patients, despite a history of recurrent loss, will go on to have a healthy pregnancy without us or without any specific intervention. So when we're evaluating an intervention, especially something as expensive and invasive as IVF, we really want to be certain that this couple's chances are significantly better with the intervention than without. And that's where the controversy lies. One of the things, as I mentioned, that brought me into this field is that there are myths and there are beliefs that this should work, therefore I'm doing it. And I have an example of, it worked for me or it worked for my cousin Susie. And so therefore it will work for everyone. And we have to be very cautious in medicine about saying what worked for me is going to work for somebody else. And so that's kind of the nuance, and that's what we have to do when we're deciding whether this treatment will be helpful for someone or not. We didn't talk too much about this earlier, but I think maybe most of the people listening will know this, that chromosome abnormalities in the eggs and sperm are very closely tied to the age of the parents. More closely tied to the female than the male, but really can be linked to both in most studies. So for couples who are, in their late 30s or early 40s, they're going to be at higher risk for having another miscarriage with a chromosome problem than, say, a younger woman in her early 30s or 20s. So when we look at who's going to benefit most, we really have to think about that. What are the risks that this person's going to have another chromosome abnormality in their next loss? And what are their likelihood of having a success without this treatment? So It's very inviting to consider offering it to everyone, but we really have to balance those recommendations. But I do think that there are some benefits for a lot of patients, and it's worth having a conversation with somebody who can really individualize your chances with and without the treatment, and then you can make a couple can make that decision. Does it make sense for them or not?
Yeah.
Like I said, it's not as simple as it works for everyone or works for no one, but can be useful in the right circumstances.
Yeah.
Also, I think what Dr. Tise was referring to is that there are other types of genetic conditions besides chromosomes that we could also screen for. So maybe you want to touch on that a little.
Yeah, absolutely. I think PGTA, with the A standing for aneuploidy, is getting a lot of buzz right now, but there is another screening. I have to say, as a geneticist, it's called PGT with the T for testing, but I would love that to be clarified to S because it's actually screening. But nonetheless, for families where there is a known underlying genetic condition, whether or not that's manifesting as individuals in an adult condition, in a pediatric condition, or in some cases, manifesting as recurrent pregnancy loss, and I'll just point out, there are some biochemical and medical genetic conditions where we know that embryonic lethality is part of the phenotype that can present. And in those cases, the testing or screening that's being done is at the single gene level, specific to the disease running in that family. It's a different type of test, uses different type of technology, but the underlying message for both is that, with PGTA, I think you're getting at chromosomal differences where the vast majority are not inherited and most are sporadic. When you're getting into PGTM, where M stands for monogenic, single gene, you're getting more into the inherited, and you need to identify the cause in the family first before you can ever screen the embryos.
Okay. And some of those things might be, I'm assuming, or please comment, that some of those things might be, just based on past medical history, and some of those things might be identified as part of the workup that you're going through as part of your fertility treatments.
Yeah, and sometimes they're identified in prior children. And, in some situations, there are diagnoses where we knew the child their previous children had something, but it's not until the year 2022 that we're actually making that diagnosis. And I think that's the really hard and heartbreaking part. It's great we're providing these families a diagnosis. You feel bad for the years they were told this wasn't genetic, but I think we'll discover more as we move forward.
Which, we're about halfway through, so I want to transition to start talking about the moving forward piece. So you have this incredible grant from the NIH. Let me start really broad and say, tell us more about the project and what are the aims and what are you hoping to find? I'll let you just speak kind of broadly to start.
Okay. Well, we are a multi-site study with multiple specialties actually involved. We have neonatologists, we have geneticists, OBGYNs, computer scientists, all working together to try to solve this complex problem called pregnancy loss. We know that no one test or one field is going to have all the answers. And particularly with something as complicated as developing a human inside another human's body, there's going to be so many factors. So we are taking what's called an agnostic approach, which means that we are throwing away all of our hypotheses, collecting a bunch of data from patients with any history of recurrent pregnancy loss and following them over time. Which factors at presentation, which is like when I see you the first time, predict whether you're going to be successful or you're going to go on to have another pregnancy loss. So that comes up in our registry, which means is just purely we're trying to identify algorithms or patterns in a clinical history that predict future outcomes of future pregnancies. But what our main funding is looking at is novel genetic causes. So we are for patients who have experienced or chromosomally normal pregnancy loss. So we kind of talked about the importance of looking for chromosome abnormalities to give an explanation, but that other half that is unexplained by chromosomes, this is where our research really gets going. And for couples who have experienced chromosomally normal pregnancy loss, we are doing more additional testing, including performing whole genome sequencing, looking at all the genes, not just the chromosomes, of both the sperm and egg source as well as the miscarriage, to try to explore for these genes that can cause pregnancy loss. And how are they inherited? Are they new mutations, or are they inherited from one of the parents? And do these genetic patterns that we find predict subsequent outcomes? And ultimately, the goal will be to identify targets for treatments and families who would benefit from IVF and genetic screening of embryos. But we also are exploring other options, and that's what this agnostic or really broad brush approach. We're collecting data about environment, about immune systems, about metabolics, lipids. So we have a very, this is kind of a trendy term. It's called multi-omics, meaning that we're looking at all the genes, all the metabolism, all the medical records, all of the, the omics is just like a fancy word for a whole bunch of metabolic factors. And then we're going to be relying on our computer science colleagues to find these patterns. How do the genes present? Are these genes active? Are we seeing the gene products going up or down during pregnancy? And how does the genes and the environment interact? Is there an interaction between the two parents? Is there an interaction between the embryo and the mom that when these genetic combinations occur, that causes loss, but a different combination of those same genes might not cause a loss? So it's going to take some time for the analysis, and we're really kind of appealing to try to enroll as many patients with as many different types of pregnancy loss histories who want to help us to provide us with that diverse background. We don't know if there are overlaps between early pregnancy loss and late pregnancy loss. We also don't know if the causes of male pregnancy loss are the same as the cause of female pregnancy loss. So we're still looking at all of those factors with a completely open mind, because we know that the current approach has not provided answers for over half of our patients. So we're kind of assuming that the current thing is not working, and we're going to look for brand new causes.
So, and Dr. Tise, I know you probably have a lot to add to this. I want to, because that idea of like, we're kind of going at this with no hypothesis, throwing out what we know. Can you dive a little deeper into why that's important? Because obviously there are known clinical factors that might be predictive. Why is it better to come at this from that broad-based approach versus like, hey, we know that phospholipid syndrome might be related to this, and so we're just going to really specifically dive into genetic, the genes related to that piece?
Great question. And just a plug for that registry that Ruth mentioned, the HOPE registry, for anyone who's interested, and I'm sure, Megan, they can reach out to you. I think to some degree, history has served us well in genetics to look back and realize how complex things are beyond our wildest dreams or imagination. Even hearing Ruth describe these interactions that are probably 100% true and playing a role is probably just touching the surface of the complexity of all of these interactions between genetics, the environment, the biochemistry, metabolism, things, and a lot of which are things we can't control or aren't even aware of. And I think, kind of for that reason, going forward, realizing how little we actually knew about the human genome when we thought we understood all of it, when it was sequenced, and realizing we don't really understand much of it, and realizing there's things beyond the sequencing of genes. There's methylation patterns, there's epigenetic factors, there's parent of origin things that contribute. I think this is the right approach to go in with an open mind, so that when you see things, you can appreciate them, observe them, learn more about them, add to the body of medical and scientific literature, help patients. I think if you go in with a narrow focus, you're going to miss a lot of what is offered to you and right there in front of you.
No, that makes sense.
Yeah, and I think that and I'm sure a lot of the listeners are going to echo this, is that our current guidelines, what we think we know, really doesn't help the majority of our patients. And so we're not totally throwing that out. Of course, we want to know what the natural history of phospholipid syndrome is, but even the literature on that is quite old, and our ability to detect early pregnancy losses has really gone up dramatically in the last several decades. Phospholipid syndrome was, first described, probably 40 or 50 years ago, and wow, things have changed a lot in medicine since then. We're just evolving, and I think that we want to be open to the interaction of all these factors. There's very, very, very little known about male causes of pregnancy loss, and actually very little known about uterine causes as well. I think there's a lot of hypotheses out there. There's associations, but we talk about this in science that, okay, if you have, fibroids, you might have a higher risk. You don't always, but you might have a higher risk of miscarriage. But how or why or which fibroids cause a higher risk of miscarriage and which ones don't we have to worry about? So most things in our field are kind of risk factors. They're not so absolute. So when we talk about that, learning about the interactions is really going to make a difference. And so we can help individualize our approach. The one size fits all is absolutely just not going to work for this diagnosis. I can tell you that right now.
Yeah. No, so walk me a little further down that path, right? So as you start to look at these interactions, you start to identify something that might either be predictive or that, resulted in loss and may potentially result in future losses. Then what? Like, how does this eventually translate into new or different diagnostics or new and different treatments? Like what, I know that that's going to take some time, but how does it turn into a difference in clinical practice?
Gosh, it's going to depend on what we find. I mean, there are some successes in OBGYN where we found that, say, folic acid deficiency caused neural tube defects. How simple is that? We can now prevent neural tube defects by giving women folic acid. Wow. We would love to find that answer for recurrent pregnancy loss. If we're too focused on genetics and we forget about nutrition or environment, we might not see that. So by looking at the metabolites and looking at sort of these multi-omics approach, we may see nutritional differences and genes turning on or off that could be treated with something as simple as folic acid. I mean, I don't know that it's folic acid, and that's just an example of one success that we've had through research. Who benefits from blood thinners or aspirin? We know that if we give blood thinners to everyone, it's ineffective. But are there ways that we can determine through these profiles that there are patients who have a need for blood thinners or more folic acid or give progesterone? How is progesterone metabolized different in one group or the other? And I think that if we see these differences, there may be treatments that are not IVF based that would be lovely to give people the opportunity to conceive the old-fashioned way if possible, or with less invasive technologies. On the other extreme, if we do find an inherited pattern, like Dr. Tise was discussing, that there is a lethal gene in this family, then we can go to treatments such as IVF, screen embryos for these lethal genes, and find those embryos that have a better chance at making it all the way. So I think it really, that's the beauty of this, is like we're learning so much from each other. There are 21 of us working on this grant together from our different backgrounds and histories, that we're learning, that there may be a lot of different potential outcomes from this research. And we're hopeful that the research will go beyond the current grant, but we do have several years of funding to at least get started. Right now we're just hoping to get as much information as we can and look for hints about where to go next.
So then a couple questions about people that might want to get involved in this, because there are different pieces of it. So if people are listening and thinking this is really cool and how can I be involved or how can I help, what are the ways that people can participate in this study or in the different pieces of the study?
Yes. So one of the pieces is the HOPE registry. So this is a registry of individuals who are experiencing recurrent pregnancy loss. And just as Ruth mentioned, you know, we will kind of follow these individuals longitudinally from the beginning and then throughout additional pregnancies, if there are additional pregnancies and beyond. And then just being part of that registry provides us information. What were some risk factors from the beginning? You know, these might be risk factors we don't identify right away, but once we have a registry, you know, let's say in the hundreds or thousands of individuals, we might start recognizing some of these, maybe not necessarily causal, but correlating risk factors or protective factors. But as, you know, things progress and we are able to get some outcomes data and or enroll individuals with genetic information, we're also able to enroll them into things like the TRIO study, which is really, you know, focused a bit more on the genetics of pregnancy loss and the genetics of the mother, the father, and the product of conception or fetus, and kind of help provide some answers. You know, I think something I talk to Ruth quite a lot a bit, you know, as a geneticist who, you know, sees adults, pregnant women, but mostly children, is that there are a number of children, unfortunately, in this country and across the world that, you know, die very shortly after birth. And so, you know, where in the continuum of just embryonic health and neonatal development does that fall? And so are some of these presenting as neonatal death when others are presenting as, you know, a pregnancy loss with recurrence just because of slightly different factors? And is it all just the same problem that we need to just be open-minded and agnostic to answering? So those are the opportunities that are available through this. I think, you know, getting involved with the HOPE registry, just as any family with recurrent pregnancy loss, is a great opportunity to be involved as interested and go from there.
Yeah. And just to add to that, really the starting place is through the registry, and for families who may be interested or eligible for additional studies, we will reach out to them directly. They can opt into participating in additional studies. If they're interested in being considered for sequencing or for this kind of multi-omics approach, we will talk to them about those different options. Kind of, we have like 4 aims. You know, the easiest is just, you know, help us by telling us what you know and what what's happening to you, what tests have you done, what treatments worked for you, what treatments didn't work for you. These are the types of information we really want to know. And then it's easy enough to provide a DNA sample. We can mail a saliva kit if somebody's willing to provide that for us. Then we can add the history to the genetics, and then, you know, we can follow up from there. So I think sometimes people think, I'm not trying anymore, or I already have my baby, so what can I do to help? Everybody's story, no matter how it begins or ends, could be useful to us in our research, because I think we really need to know really what is really happening out there, what's working, what's not, and consolidate it into a larger data set. So we hope that patients don't mind sharing their histories with us. I know it's difficult. I think probably we sometimes feel a little bit bad asking people to kind of go through those hardest moments of their lives, to share those moments with us. But we do so much appreciate it. We are going to use that information to really try to help make a difference in this diagnosis. Our website, I think you have it, Megan, I can send it again.
Yeah.
PregnancyLossAnswers.org really describes all the different aspects of the study that are currently open.
Yep.
And patients can just sign up online through that website, or send us questions that, we can, answer your questions and tell you more about the different aspects of the study. Most members of our team are listed there, so people can kind of understand, is there somebody looking at male factors? Yes, Dr. Eisenberg is looking at that. Who's doing the, computer science? Oh, that's Mike Snyder, and so you can learn a little bit more about what we're doing. Some people think we might have put a little too much information on our website, but I think that this is an area where, we really want to share what we're doing with everyone. And as we develop results, we will also put that on the website.
Yeah. No, that's great. Couple other questions specifically about the registry and some of the other parts of the study. For the HOPE registry, I just want to make sure that some of the, and then for some of the follow-up studies that people might participate in, you guys are all along the West Coast. All the multi-sites are mostly along the West Coast. So how does it work if somebody wants to participate and they are nowhere near Stanford or any of your other locations?
Well, we just added an East Coast site. I think it's going to be live in January, which is University of Pittsburgh, which is great for people local to Pittsburgh. But the vast majority of our study activities can be done remotely. The registry is obviously remote. If you are able to or interested in providing us DNA samples, if you can't come to one of our sites, we can send you a saliva kit. And, for those who unfortunately do go through another miscarriage and that turns out to be chromosomally normal, the majority of reference laboratories have been willing to send us that DNA. So we actually have a number of participants from non-West Coast places who are participating in our sequencing cohort, where we were able to have, say, a reference laboratory send us the sample for sequencing from the miscarriage. We sent saliva kits out, and we now have DNA, and they're doing sequencing. So it really doesn't require any in-person visits. We, of course, would love to see everyone in person. And there are some additional samples that can be useful for patients who are local. For example, we're collecting urine for environmental studies. We're collecting hair and blood for those who are willing. That's not a requirement, but these are just our ability to start to look at those future studies down the road. So no need to be local for the registry or for sequencing.
Awesome. And I just want to, because we're nearing sort of the last few minutes, so as we kind of move on from this conversation about the research project, I just want to re-say it's pregnancylosanswers.org is where you can go and find out all the more information about the specific sub-studies and how to participate. So, and I'll make sure I put that in the comments when this gets posted. So as we sort of move to wrap up, this is a multi-year, multi-site project. The stuff that you will learn from this will, benefit for probably generations to come. And a lot of these families are trying to have a healthy baby yesterday. So what would you say to people that are listening that they're super interested and invested in all this work, and they really want to have something that they can do now? What's the advice for couples that are trying to conceive that have experienced prior loss?
Well, I can take it from a genetics approach. I think kind of like the RPL Association registry and the HOPE registry, I think putting multiple irons in the fire is not a bad idea. So I think participating in research, yes, probably, can definitely not promise that we're going to provide an answer to you in the time frame that you're hoping to reproduce. At the same time, I have to say, as a geneticist, the amount of genetic testing that has become available even in the last 12 months on a clinical level is astronomical. And we're applying it clinically. It has taken a little bit of time for it to move from research into clinical practice, but a lot of that is because in medicine, we like to be super careful and have evidence-based practice. But with, improvements and technology advancements with reproductive technologies, just with genetic testing in general, I think I could probably name 5 different genetic tests that can be offered to people all before a child is even born, multiple tests that can be offered before a family even conceives. I think the American College of Medical Genetics coming out with guidelines and suggestions that every woman be offered carrier screening for genetic conditions that may be in their family that may or may not be contributing to something like recurrent pregnancy loss. But the reality is we don't know for sure. And the concept that being a carrier for something doesn't manifest until pushed to a very stressful situation would not be novel. And turns out pregnancy is quite stressful on the body from a metabolic standpoint. So I think there's carrier screening that's now available. There are situations in where, you know, microarray is often offered to all pregnant women. But, you know, there's NIP screening, the non-invasive prenatal screening. There's changes happening at state levels as to what to offer women. There's changes happening at these big colleges and societies as to offer women. But there's also the implementation of testing that we're doing on children and adults, like exome and genome sequencing, which are broad, comprehensive testing that we are starting to offer to pregnant women and their families for fetuses where we have a concern there could be an underlying genetic etiology, where the answer to get something now is very clear that it would be helpful to this family. And I think that's only going to continue to improve and increase. And it comes back to the same point of, I think for a long time, you don't know until you look. Yeah. And we didn't have the ability to look, and we are starting to get it. I wish it was more accessible for more women and more men and more families and more children. But I think it will increase in time. And so advocating, you know, I think there's the ability for families to advocate for these changes, you know, on a political, on a state, on a government level, you know, and support these colleges that are really trying to do well by their patients.
I guess just to follow up on that, I think, Megan, you know, your question about what do people do now, we are constantly trying to make the world better for women who are trying to have children. Pregnancy loss is more common than anyone ever thought until they start looking at the numbers. There are estimated 23 million miscarriages that happen every year, and it's tragic. And we need to answer these questions for families. But the number one advice I have for my patients and for really the community experiencing recurrent pregnancy loss is that for a very, very, very high percentage of you and a very high percentage of my patients, even without a concrete explanation, many, many, many women and families will go on to have a successful pregnancy. It doesn't make sense. Our neurobiology of wanting an answer to provide, to get to the outcome forces us to go down this path of, if I tried the same thing 3 times and got the same answer, our brains just think that the 4th time it will be the same. And the statistics are the opposite, that there's a lot of reasons to be hopeful, even in the setting of unexplained recurrent pregnancy loss. For patients who have experienced 3 consecutive pregnancy losses, success rates are typically reported at 60 to 80% that they'll be successful if they keep trying. And that's the hardest thing to tell a patient, that I don't know why, but I do know that there's a good chance that you could be successful next time. The only thing the only explanation I can give to that is that it has to be a combination of factors. Every time you get pregnant, it's a new egg, it's a new sperm, it's a new uterus lining. Maybe the nutrition is different, maybe the stress levels are different, but that mixture, every time we get pregnant, we have a new chance to be successful. And as hard as it is to keep trying and be hopeful, there's a lot of reasons to be hopeful. And I do encourage patients to keep trying, not to give up, do the best they can with their health and their environment, and most will be successful. It's really what keeps me going, is that even without answers, we're able to help so many people through this.
Yeah, and I think the advancements of these 2 fields happening simultaneously, kind of both being relatively nascent fields in medicine, but probably the fastest accelerating fields, is only just going to be synergistic.
Yeah. Thank you so much. There were a couple questions. I don't typically have ask the questions that come in while we're live, but there are 2 that were related to registry participation, so I do want to ask them. So to participate in the HOPE registry, is, just to be clear, can you join? Is there how many losses does somebody have to have in order to join the registry?
1.
And then
I
another.
think every miscarriage matters, and patients who have one miscarriage come with the same questions as patients who have 3. Why, and will it happen again? And that's what we're trying to answer for everybody. So 1 or more loss, you could be male or female, all genders, all methods of conception. We really want to really pull in people with every type of history.
And then another question was, and I knew that answer, but this one I actually don't know. Repeat implantation failure, does that qualify for enrolling in the registry? It's sort of related but different than pregnancy loss.
Related but different. Yes, I agree with you on that. I do think there's a lot of overlap. It still takes a healthy egg, a healthy uterus, and healthy sperm. So there our bar for entry is at least a positive pregnancy test.
Okay.
So you need to have a pregnancy of any gestational age. It could be 4 weeks and 1 minute, and your pregnancy test is positive. But just for the purposes of this study, we had to be as broad as possible, but also respond to, the question about what causes pregnancy loss after implantation. We are doing lots of studies at Stanford and other places on repeat implantation failure as well. And I believe there's a huge overlap, and I'm interested in that field too. But this particular grant, this particular study is for pregnancy loss at any gestational age. Could be 4 weeks all the way to 40 plus weeks. So any gestational age, no limit, but has to be pregnancy positive.
I want to thank you both again. It's a treat for everybody that gets to hear from both of you, and I'm personally very excited to continue to follow the work that you're doing with the Hope Project. And there was actually a comment that just came in. This gives me so much hope, and it's all capitalized. So I think that's exactly the point. So thank you both so much for joining me. And yeah, I can't thank you enough. I'm very excited, and thank you for all the work that you do and your interest in this community and this condition.
Well, thanks for organizing, Megan.
Thank you so much.
Yeah. All right. Have a good rest of your evening.
Have a good evening, everybody.
Bye, everyone.